Well, welcome for today's program that is entitled Roadmap to a World Free from Diabetes. And we have really a tremendous treat today that we're going to have Chuck Henderson, the CEO of the American Diabetes Association, and Rita Kalyani, who is the Chief Scientific and Medical Officer. So they are the two high-level staff at the ADA. And they're going to tell us about what the ADA is planning to do to reduce the prevalence of obesity, complications of diabetes, how we can end the stigma associated with the disease. So to do that, let me briefly introduce Charles or Chuck Henderson. He has more than over 25 years experience driving innovation in industry and private uh, areas, and have been the chief CEO at the ADA for the past 5 years, I believe. He does a full desk. The ADA, just for information, have over 500,000 volunteers, 12,000 professionals, and it has a tremendous budget. So he spent his life leading the organization. On a personal way, I know Chuck for many years. He's a tremendous guy. Something that Venka doesn't know. He used to be a professional basketball player. I remember the first time I had dinner with Chuck, and I said he was a professional basket player. Of course, he must be close to 7 feet tall. And Rita Kalyani has been my friend for many years. Was a faculty at Hopkins for many years. I'm sure that most of you have read her papers. And NIH funded for who knows for many years. And she has written over 200 publications listed in PubMed and many textbook chapters. She recently joined the ADA as the chief scientific medical officer. She's the person and the staff in charge of the standard of care. As you know, it was published the standard of care a couple days ago. So she had been pretty busy in the last few months leading this group. So let me ask Chuck to go ahead and start his presentation.
Thank you so much, Guillermo. And just to note everyone about Guillermo is one of my favorite people in the world. Enjoyed when he was on our national, one of our national board members, Guillermo. So thank you for that kind introduction. But good afternoon, everyone. As Guillermo said, I'm Chuck Henderson, CEO of the American Diabetes Association, and very honored to be with you all today. But first and foremost, I want to share my appreciation for the work and studying that you all do. From a public health perspective, it is more important now than it's ever been in many of our lifetimes. I know that this work can feel very daunting at times, but living in a household, my mom taught nursing for 42 years. And so I admire your strength to keep going because it definitely makes a difference for everyone, especially for the millions of Americans with chronic diseases like diabetes and obesity. Next slide, please. And when I think about, how prevalent this disease is, when I think about the nearly 1 in 2 Americans living with diabetes or pre-diabetes, this year the ADA is celebrating 85 years of progress and purpose, where we've led the charge to prevent, manage, and eventually find a cure for diabetes. And as a lot of people know, I'm big about the history. And so when I think about when the ADA was founded, it was founded in 1940. And I always like to talk about our mission, right? And so that's to prevent and cure diabetes and improve the lives of all those affected by diabetes. And so since that time, over the 85-year history, the ADA has driven research, advocacy, education, and programs to help people affected by diabetes thrive and live their best lives. And so, one of the most important lessons that we've learned in our 85-year history as an association is every single thing we do matters. And so when I think about every new scientific discovery, when I think about every advancement in care, when I think about every policy breakthrough, and active advocacy, When I think about every conversation that we have, every partnership, it absolutely all matters. And as Guillermo shared, I've had the honor of serving. It'll be 6 years, January the 6th at the association. And I've had the honor and privilege of serving as CEO of the ADA for the past 3.5 years. And so, personally, I've never been more excited about the direction that we're headed to ultimately being a world free from diabetes and its burdens. I always say that, this is a great time from a technology advancement perspective to be, living in this time or dealing with any chronic illness for that matter. And so with that, I want to walk you through our ADA strategic roadmap on how we move forward towards a world free of diabetes. Next slide, please. And so you'll see, I'm very fond of strategy and our roadmap, and I always carry this around with me everywhere I go. And so when I think about our strategic plan, is guided in 4 pillars: research, advocacy, education, and connection. And so we work across all of those 4 pillars for each of our focus areas, which are diabetes prevention and management, health access, nutrition and wellness, obesity, and primary and collaborative care. And so when I think about where our North Star is as an organization, we need to double down our efforts to provide the very best resources for everyone affected by diabetes and obesity, as well as for the healthcare teams who take great care. That many of professionals like yourselves on the phone. And so when I think about our focus on diabetes prevention and management is foundational to everything that we do as an association to strive to achieve a world free of diabetes and all its burdens. And so thus you will see it woven throughout the other focus areas that I discussed. Next slide, please. And so our next focus area is health access. Our goal for health access is to be the voice of people in resource limited communities who are at higher risk for diabetes and obesity by tailoring outreach, improving access to education and resources, fostering trust, and addressing barriers to care. And so when I think about it from a research perspective, because I know that that's, very near and dear to your heart, Guillermo, from a research perspective, it's all about ensuring that the research we support addresses the needs of all populations and also addresses the social factors that impact someone's health. And so as we think about, how advocacy relates to that, we're pushing hard on policymakers and we'll continue to do so to approve policies and funding that ensures everyone with diabetes and obesity has affordable access to the care that they need and deserve. And so again, when I think about around education, we continue to plan to equip healthcare professionals with information and tools they need to engage at the community level and meet patients where they are with care. And then for connection, we absolutely have to be connected to the communities. We need to work locally to provide we need to make it simple, evidence-based education and improve the health literacy of individuals so that they can ask for the care that they need. Because as many of on the call, we only have a limited amount of minutes when we see our primary care professional, and it takes a little bit of time to see our endocrinologists, which we need more endocrinologists in the field of diabetes. And so one of the other things that I like to talk about is nutrition and wellness, because that's actually key in how you take better care of yourself. And that's an area the ADA has long been focused on, but more recently has had a spotlight shown on it nationally across all chronic conditions. And so again, our goal for nutrition and wellness is to be recognized as a trusted authority in translating the nutrition and wellness consistent statement into practice to build healthy habits. And so again, there's a lot of research in this area that we definitely want to continue, but the research is only as effective as the action it inspires. And so again, thus, as an association, we aim to better draw the connection between nutrition and wellness research, and then the positive impacts putting it into practice that this has on individuals. And on the advocacy front, We know that everyone has the access they need to healthy foods and environments that encourage wellness. So we will continue to support and elevate those policies. And then as we think about education and community connections related to nutrition and wellness, it's very similar to our objective around research in this area. And so, again, about ensuring that healthcare professionals and people living with diabetes and obesity have the knowledge they need to turn the research and guidance again into action, make it actionable so people can arm themselves to become healthier or to maintain their health. And so, again, that's easy applicable to the community in which people live. And then I want to touch on obesity a little bit. We all know that obesity is an epidemic with more than 2 in 5 U.S. adults living with obesity. And in addition, obesity accounts for up to 53% of new cases of type 2 diabetes every year. And so in our quest from an association standpoint and our volunteers, like many of you on the call, we need to get further upstream to reduce the prevalence of obesity. And so in 2024, the ADA launched the Obesity Association, which is again a division of the ADA. It's under the American Diabetes Association, so we can, change the narrative and the future for those impacted by obesity and related chronic diseases. And so again, the impact is staggering with obesity linked to over 200 conditions. And so again, the launch of the Obesity Association is just the first step in our intense focus on changing the conversation around obesity and the need to remove the stigma and shame that is often associated with it, along with recognizing and treating obesity as a chronic disease that it is. And so since that time, I'm proud to say that we've launched initial chapters of the standards of care in overweight and obesity that discuss how healthcare professionals can address weight stigma and bias with their patients. The next chapter will be coming out soon that begins to address our recommendations on care and treatments for people living with overweight and obesity. And again, it all goes back to research. And so from a research perspective, we plan to continue to align the standards of care with evidence-based science that improves the health and well-being of everybody affected by obesity. And then from an advocacy perspective, our objective is the same. For the health access, which is to support and encourage policies that provide access to care for everyone living with overweight and obesity. And so just like we do with diabetes, for education and community connection, we want to aim to ensure that we are the go-to source for the information that healthcare professionals can go to. And then last, but certainly not least, is our primary and collaborative care. We know that around 80% of people living with diabetes receive their care from a primary care team. So it's super important that we partner with PCPs, practices, professional organizations, that they have the guidelines to deliver the best, the most up-to-date evidence-based care to their patients in a timely manner. And so again, from an ADA perspective, we plan to partner with Primary Care Council and Diabetes Primary Care Alliance so we can make sure that we get this information out. And then last, I want to take a few minutes to comment specifically on one of our strategic pillars, advocacy. While I just shared our high-level advocacy priorities for each area, I would be remiss if I didn't share about our advocacy work, especially in an environment where America's safety net programs, prevention programs, and research, and again, research are facing funding cuts. And so again, from where I sit and my leadership team and our volunteers as a community, we are super united in this concern and a need to defend these actions in the most influential ways possible. And so, yet while I say this, I recognize that this is a very difficult fight for all of us and many of you on the call today. But I will say that the ADA's advocacy team, our staff, our volunteers, we've all been hard at work to call on policymakers to protect funding for healthcare programs such as Medicaid, food assistance programs like SNAP, and the research and prevention programs are essential to advancing the ADA's mission. And so again, you will see throughout the year that we'll run multifaceted campaigns aimed at protecting America's safety net programs, prevention programs, and research. And we're involved in direct lobbying, paid advertising, grassroots advocacy tactics. And so we continually and we will carry out all these elements as an organization and in collaboration with other partners to illustrate the strength of our collective voices. Because again, we can't do this alone. We need our partners. We need people to actually stand up. And so again, one of our taglines is it takes all of us to end diabetes, and we're all in this fight together. So again, your work to raise awareness about prevention and treatment of diabetes and obesity is critical to achieving our vision of a life free of diabetes in its burdens. And again, I'm going to be quiet and pass the mic over to Rita. But Rita will share more about ADA's efforts in research, science, and healthcare, as well as updates from our latest edition of our standards of care in diabetes that just came out last week. And so, Rita, over to you.
Thanks so much, Chuck, and thanks, Guillermo, for that warm introduction. Thanks for having us here to talk about the ADA's strategic vision, and specifically, I'll be talking, following Chuck's talk on research and what we're doing in the ADA. So as Guillermo mentioned, I'm relatively new to the role, but not new to the organization. Joined in August as CSMO, the Chief Scientific Medical Officer. Prior to that, served on the National Board of Directors as President of Medicine and Science, and as a professor of medicine at Johns Hopkins, where I focus primarily on research as a clinician scientist. So I'm very excited to talk to you a little bit about what the ADA is doing in regards to research, and then give a broad overview of our division of science and healthcare. So on this next slide, you will see some of the things that I just mentioned, driven by a deep commitment to improving the lives of people affected by diabetes and obesity, focused on expanding access. You heard Chuck mention how access is a priority for us in our strategic roadmap. So every community benefits from high quality prevention and care, motivated especially to translate rigorous science into practical solutions. And for those of you who've read the standards of care this year, I know Guillermo's already dug in or have read it in previous years, that evidence-based clinical practice guidelines is such a priority for us. And then guided by the belief that the greatest progress comes from people working together with shared purpose. And you'll see this nice photo here from our scientific sessions this past year. So this is the Office of Science and Healthcare that I have the privilege to oversee with a talented leadership team and staff. The standards of care falls under our purview, as does the research programs, which we'll talk about today, professional education, patient and consumer education, nutrition, diabetes prevention, the Obesity Association, which you heard Chuck talk about, and the Education Recognition Program. So we cover a lot of different areas and initiatives, and today I'll be focusing on research and the standards of care. So we have a long legacy of research excellence at the ADA, which we're particularly proud of. 70 plus years of transforming diabetes research. We went through the tally so we could have a number to share with you, and we've had close to $1 billion of research invested since 1952 from the ADA, and we've been focused on driving innovation for a diabetes-free future. We have many active projects, some at your institution, many at other institutions. We have 50 pathway scientists. These are our cutting edge, late-breaking science projects funded as of 2025. And much of our research that we funded has led to breakthroughs in beta cell regeneration, immune modulation, and automated insulin delivery, among others. You can see the timeline there, but really what we wanted to focus on is how long we've been in this space, how much we continue to grow, and how much we continue to focus on the needs of the community. And in 2025, we were thrilled to receive the largest foundation gift in ADA history to fund type 1 diabetes research, which I'll talk a little bit more about in the next slide. So we continue to drive bold innovation at the ADA to empower the next generation of diabetes research leaders and expanding impact. And I know at the Georgia CDTR that is a shared focus. We are proud to partner with you all and other CDTRs around the country to fund promising scientists as they embark on their research careers. We funded 55 new postdoctoral fellowships in 2025. We had many posters and abstracts authored by our early career scientists. As mentioned, a major milestone for type 1 diabetes research, and we will have a focused application coming out for that next year, so stay on the lookout for that. And this just continues to highlight what the ADA was already doing in the type 1 diabetes space, but continues to grow our footprint in type 1 diabetes. We also have the Pathway to Stop Diabetes program, which many of you may be familiar with, which is designed to inspire and fund exceptional scientists with transformative ideas. This is a $1.625 million award over 5 to 7 years. So far, we've funded 50 scientists, and we have funding to fund many more. So I encourage you to look at that request for application when it comes out, if you're interested. And these particular scientists have been authors of numerous patents, startups, and publications that have been highly cited. Our momentum, we continue to get more and more applications. In fact, we've seen a surge in the number of applications we've received at the ADA as circumstances have changed in the external funding environment, and we are anticipating this continue to grow and are looking at our pipeline. And we continue to fund new awards every year. Some of the celebrations that we'd like to share of our ADA recipients, most recently our 2017 Pathway awardee from the ADA, Sarah Stanley, had a publication here that was seen both featured on Mount Sinai and in multiple media outlets, where she discovered a connection, her and her team discovered a connection between the brain region that processes fear or anxiety and the liver, and showed how stressful situations can raise blood glucose with repeated stress and lead to metabolic dysregulation in type 2 diabetes. 2023 postdoctoral fellow Soon-Hee Jung discovered that adding dietary fiber retrains gut bacteria to better break down fructose, and that this reversed insulin resistance, fatty liver, and liver scarring. And this was published in Nature very recently. And then perhaps most recently as just a few weeks ago, there was a first author paper in JAMA by one of our ADA recipients, which looked at women who stopped taking GLP-1 medications and that are commonly used for weight loss and diabetes, and looked to see whether they were more likely to develop gestational diabetes, high blood pressure, and deliver early. And so this highlights the tremendous scope of the research that we focus, from basic science to clinical research, but also how successful and productive our recipients are and carrying forward the research community. Our 2024 research report highlights many of these findings. If you're interested, is available online. We continue to invest in innovative research ideas that address critical unmet needs across the diabetes spectrum, supporting early career scientists. That's a huge priority for us to grow the next generation of leaders in diabetes research, and then leveraging collaborations and partnerships to maximize return on investment and impact, and then bringing diabetes experts together at scientific sessions to learn, share, and collaborate, and to accelerate research progress. And I hope many of you have had the opportunity to come and share in scientific sessions in this coming year that will be held in New Orleans in June. Again, supporting brilliant early career scientists is a key priority. We increased the postdoctoral fellowship stipend levels, and allowance is above NIH levels based on feedback we received from our recipients. Record-breaking number of applications for these awards, and then many ADA-supported posters and talks from our recipients. And we continue to grow this collaborative community because we know that it doesn't just stop when you get the award, but also having that network of other research professionals for early career scientists to tap into and to collaborate with is especially important. And so we hold a research workshop in the fall. We just had it in November, and then a grantee reception at scientific sessions in June. We also have 2 targeted RFAs that were launched. We're in the second year cycle of each of those. They are active and open right now. If you have areas that you're interested in these spheres, I encourage you to look at them and apply. The first is in primary care, and the second is in older adults living with diabetes. And then again, that pathway to stop diabetes application and the postdoctoral fellowship applications as well. They come in rotating cycles, and those applications will be open later in the spring for both of these awards. At Scientific Sessions 2025, I hope many of you had the opportunity to attend and could share in the excitement, but we were really thrilled this year to have 12,700 attendees. Year over year, it continues to grow, the number of international and U.S. Participants that we have. We had 10 late-breaking clinical trials presented, almost 2,000 posters presented, in many different oral presentations as well. You can see that we had 78 symposiums, many parallel tracks designed to highlight the varying topics and areas covered in diabetes care, 22 panel discussions, 9 debates, those tend to be our liveliest most participatory sessions, and then 7 Ask the Expert sessions too. So we really are thrilled every year to host Scientific Sessions, are right knee deep in organizing it for 2026, and I can share with you that there's really many exciting sessions that'll be featured in this June scientific meeting. Again, this will be New Orleans, June 5th to 8th. Abstract submissions are open now, and also registration as well. So you can take a look and hopefully sign up, and we look forward to seeing you there. So now I'll turn to the American Diabetes Association Standards of Care in Diabetes 2026. Hot off the press, just came out last week. So don't expect that you've read it cover to cover, but glad that some have already dug in. And this is the official slide deck that you can find online. It's freely available for anyone to use, to peruse, in addition to the full 300-page plus page document that can be downloaded online as well. So just to emphasize how much the ADA Standards of Care has evolved in 35 years, it used to be just a few pages, 4 pages in 1989, and now in 2026, we have more than 370 pages of recommendations. So as you can imagine, this not only reflects the evolving evidence and research base that we've had in diabetes care, which has been tremendously exciting to see, but also the continued emphasis on the comprehensive management of diabetes. And I think you'll hear that as I go through highlights of what was updated this year. This is the process, which is important to understand in terms of how the recommendations are developed. Every year, our professional practice committee, which is made up of experts from around the country in diabetes care, go through and search the scientific diabetes literature that has been published in the past year, and then looking at those studies, grading those studies based on the quality of evidence, the study design, and methodological approach. Recommendations are revised every year according to this evidence. The Professional Practice Committee leads this process along with the ADA. The Standards of Care goes through extensive external peer review, including subject matter experts and other experts that review the Standards of Care before it goes to press. And then ultimately, the Standards of Care is reviewed and approved by the ADA Board of Directors before it moves forward in the final publication process. We also have the living standards, which I'll touch upon briefly in the next slide. And it's important to note that funding for the Standards of Care comes out of the ADA's general revenues. It does not use industry support, and it is purely out of the general revenues. The ADA Standards of Care is a living document. It has been so for almost 10 years. And what that means is that Even though we had much excitement with the publication of standards of care last week, as new trials, as new studies are published throughout the year that might change our recommendations, we have the ability to update our recommendations online to reflect that evolving evidence. So our professional practice committee is kept busy throughout the year, reviewing new studies as they come out. And if there's a late breaking or hallmark study that really warrants a change in recommendation, we have the ability to do that even mid-year. And you can find the most up-to-date recommendations in the live version of the standards of care online at that link. This is the evidence grading system that you can read more about in the standards of care. Needless to say that level 8 is the highest level of evidence, really well conducted, randomized controlled trials, evidence from a meta-analysis that incorporated quality ratings in the analysis. Level B, also relatively high recommendation, well-conducted RCTs that might have a few methodological limitations. And then level C is really supportive evidence from studies that may either be observational studies or have more methodological challenges. And then E reflects expert consensus or clinical experience where we may not have the evidence yet, but the committee deemed it was important to include for any reason. The standards of care in diabetes, again, I think hopefully many of you are familiar with it, but it is intended to provide clinicians, patients, researchers, payers, and anyone interested with the components of diabetes care, general treatment goals, and tools to evaluate the quality of care. And so it is really used broadly and widely by many different individuals. In the last year, I will share that we've had close to 7 million people access the standards of care in diabetes. And so we are really excited and thrilled to see its continued dissemination around the world. This is a table of contents of the standards of care in 2026. And what you can see is that diabetes really spans many different organ systems, many different areas, from behavioral health, mental health, to routine preventative care, nutrition, exercise, obesity, technology, pharmacological therapy, heart disease, stroke, kidney disease, eye disease, special populations, older adults, children and adolescents, pregnancy, in the hospital. And then we summarize some of our advocacy statements at the end as well. So really, we hope that this is a reference that many different individuals can access to continue to raise the level for the standards of care in practice. I'll focus briefly on the highlights from the standards of care in 2026 and the supportive recommendations, just to give you a very high level of what has changed this year, but definitely encourage you to read through any of those sections that may be of interest for greater details. In the diabetes technology section, there is new guidance that recommends continuous glucose monitoring use at diabetes onset and any time thereafter. There's new guidance removing the need to meet certain requirements, such as C-peptide testing before initiation of CGM or AID systems in people with diabetes. In the topic of glucose-lowering medications, there's new guidance on obesity pharmacotherapy, dose individualization in people with diabetes. There's also a new section on treatment of obesity in people with type 1 diabetes. We have expanded guidance on glucose-lowering therapies in people with chronic kidney disease, including in those with dialysis. And then in the nutrition section, there's guidance on eating patterns with evidence for preventing type 2 diabetes, which I'll share more about. And then under diabetes management, updated blood pressure goals for individuals with high cardiovascular or kidney health risk, and expanded guidance on screening, monitoring, and use of diabetes technology in individuals at risk for type 1. Then a few other noteworthy changes that you can see there: guidance on behavioral health screening and referral, information on supporting diabetes technology use in the workplace, new and updated algorithms on insulin therapy in type 1, new information on emerging technologies in foot care, updated guidance for older adults, including CGM use, updated guidance for children and adolescents, including nutrition education and the need for that, and screening for psychosocial concerns, and the new hospital guidance, including glycemic goals in the perioperative period and technology use. So I won't go into great detail for all of these, but I did want to share the recommendations from the standards of care so you could have a preview of what's in there when you do have a chance to read more about it. So general device principles. So this is from the technology section and the guidance that I mentioned. And this specifically talks about healthcare professionals working with people with diabetes should be aware of the technologies and seek additional support when needed. Recommendation 7.7 for adults with diabetes using diabetes technology. Reasonable accommodations in educational and work settings should include having time to manage their devices and responding to high and low glucose levels. You will notice that all the recommendations on this slide are level E. They're expert consensus because we may not have the evidence we need or would like to make this a higher level recommendation, but these recommendations have implications for policy, for advocacy, and then also on quality of life for people with diabetes and coverage, which is part of the reason that they were included in the standards of care. Recommendation 7.8 is that new recommendation that talks about early initiation, including a diagnosis, depending on a person or caregiver's needs and preferences. And then 7.8a is the addition that there should be no requirement of a C-peptide level prior to initiation of CGM or for coverage, or the presence of islet autoantibodies. There should be no requirement to have a long duration of insulin treatment before the initiation of these devices as well. And so this is important to keep in mind when we talk about aid systems and insulin pump use, that these requirements, based on the current evidence that we have to date, really the committee decided and agreed that there should no longer be these requirements. And then again, having the availability of standardized reports so that healthcare providers and patients could read the outcomes of their testing and look at patterns in CGMs as well. Use of CGM is recommended at diabetes onset and any time thereafter. So that's that new expanded recommendation 7.15 for children, adolescents, and adults with diabetes who are on insulin therapy, level A recommendation, and on non-insulin therapies that can cause hypoglycemia, level C, and on diabetes treatment where CGM helps in their management, level C. So we have seen emerging evidence and increasing evidence in people even not on insulin for the use of CGM, which is reflected in those recommendation levels as well. And then in people with type 2, in people with diabetes on insulin therapy, CGM devices should be used as close to daily as possible for maximum benefit. And then recommendation 7.17 talks about its use in pregnancy. This is a new table, 7.3, that is in the standards of care this year, and you will see not only the real-time CGM devices that we currently have by prescription available on the market, but also the over-the-counter CGMs that we also currently have available on the market, in addition to the professional CGMs as well. So this is a nice table to really summarize the current CGM devices that are available in the United States and available for both healthcare providers and people with diabetes to have access to. And then this is an updated table. This was also there last year, but again, updated with new information on interfering substances for each of those devices and medications or other ingredients that might affect these and how to be aware of them in terms of interpretation of blood glucose levels. The next section that I'll just highlight some of the new recommendations is the obesity and weight management section, section 8. Again, this has many different recommendations in it. Recommendation 8.17, obesity pharmacotherapy should be considered for people with diabetes and overweight or obesity along with lifestyle changes. Potential benefits and risks must be considered. That's a level A recommendation. And recommendation 8.18, In people with diabetes and overweight or obesity, the preferred pharmacotherapy should be a GLP-1 receptor agonist or a dual GIP-GLP-1 receptor agonist with greater weight loss efficacy, especially considering their added weight-independent benefits, level A. And that was based on the evidence that we have to date and is summarized in this section if you want to read greater detail for the evidence that supports these recommendations. And again, recommendation 8.20 is the expanded recommendation that talks about individualizing the dose and dose titration of obesity pharmacotherapy. So there's no requirement for step therapy or coverage to balance effectiveness, health benefits, and tolerability. The optimal treatment dose for the individual may not be the maximum approved dose. That's level B. And then recommendation 8.21, in those not reaching their weight goals, modify or intensify treatment with additional approaches, including lifestyle or metabolic surgery or additional agents as indicated. And then in section 9, I'll just go through this very quickly. Again, this is really the heart of the algorithm, which we've seen evolve over the years. These are the supporting recommendations. I won't go into great detail, but I just want to share with you how many there are for pharmacological therapy. What I did want to share is the algorithm. So this is the algorithm, which looks similar to the last year with some updates as well. And again, we recommend healthy lifestyle behaviors, diabetes self-management, education and support, and an assessment of social determinants of health from the beginning, and then assessing whether the person with diabetes has cardiovascular or kidney comorbidities, which would take you down a different path, as you can see here in terms of the preferred pharmacotherapy initially versus a goal of weight management, which you can see over there on the right-hand side, or achievement maintenance of glycemic goals. So the ADA standards of care really takes approach of looking at the individual and guiding treatment appropriately depending on the comorbidities and the goals of care. And just briefly, we also have the addition of mitigating risk of MASLD or MASH as well, which was added to the standards of care to emphasize the importance of diabetes and liver health, which we've had more and more evidence in the recent years, and we've had more and more recommendations in the standards of care as well. And then section 5, facilitating positive behaviors. This is the table summarizing nutrition behaviors to encourage. This was in the standards of care in various sections before, but really having it in one place. So when you get that question of what should I eat when I have diabetes, these are the nutrition behaviors that really we are encouraged based on the latest evidence. And then cardiovascular disease and risk management. Lastly, section 10, again, there's 4 pillars to that: glycemic management, blood pressure management, lipid management, and then looking at agents that have specific cardiovascular and kidney benefit alongside the very important base of lifestyle modification and diabetes education, with the goal at the top there to reduce diabetes complications. And blood pressure goals in recommendation 10.1 were updated to say individuals found to have elevated blood pressure without a diagnosis of hypertension should have blood pressure confirmed, and hypertension is defined as greater than 130 over 80, and then counseling all people with hypertension and diabetes to monitor their blood pressure. And with that, I will pause. That was a lot to cover, very high level, but I hope it gives you a sense of the breadth of the standards of care and the research programs at the ADA. My email address is there. I would love to hear from any of you. And with that, I think ready for any questions. Thank you.
So let me start with a question. I don't know for you, Rita or Chuck. I received a text from one of the attendees. It says, "How can I serve in an ADA committee?" So how many committees, how can I serve in one of the ADA committees?
Yeah, Rita, go ahead. Yep, I'll defer to you on that question.
Yeah. Thanks for that question. That's a fantastic question, and one of the priorities for me as the new Chief Scientific Medical Officer is to foster increased professional engagement, to have especially people who have not had the opportunity to be as involved in the ADA to be involved. And so we would love to have your interest and your engagement. You can reach out to me at that email and I can forward you to the appropriate link. But we have a call for applications every fall. You can find it on our website for our national committees. It's an open application process. It asks a few questions. It'll ask about your interests and your the committees that you might be interested in serving on. So I encourage you to look at that application online, but otherwise, just contact me directly and I can forward you to the right resources. But we would love to have your interest and to hear from you.
Yeah, and I'll just add, aside from the professional committees, I mean, there are many, many other ways to get involved in the ADA. We have our local community leadership boards, and we actually have an executive director and a team in the Atlanta market. We have our walks, we have our tours, we have many, many different ways of getting involved at the ADA. And yeah, as Rita said, if you have any interest, please contact her directly. But you can also go on diabetes.org. I think it's /get involved. And so there's a number of different things, the different programmatic things throughout the year that we do to emphasize the importance of our mission. So
another question that I got is about less than 10 to 20% of patients with type 2 diabetes receive formal education. So what is the ADA doing to improve the access of patients with diabetes to get formal diabetes education?
Rita?
We have our diabetes self-management education programs, the education recognition programs. And, this is something that while we have, actually the ADA is a larger provider of ERP accredited programs in the United States, we know that there are pockets of the country where we still have yet to expand our reach. And so we are looking for ways to continue to get those programs, those vital education programs for people with diabetes to those communities. We have the diabetes prevention program. We have other primary care and primary care alliance, which my colleague, Dr. Rastogi, oversees, which is really looking at the communities and primary care clinics so that people with diabetes can be met where they are in the community. And so we have a lot of complementary initiatives really to foster that important diabetes education. Our professional education programs complement those so that the healthcare providers can also be educated on the need. But I think what this question highlights is the importance of recognizing areas where perhaps historically there have been disparities or where we've seen, challenges in access. And so this is where we are continuing to focus our efforts to reach those communities through those programs.
Yeah, and then Rita, could you also touch on some of our partnerships with Genentech addressing diabetic neuropathy? We have the partnership with Abbott, we have the partnership with Lilly in clinical trials, and so I think that's another way. When we get funding for those programmatic things, those are resourced in community. So when you think about Birmingham, Alabama, what we're doing with Genentech, and in DC, could you kind of expound on some of those things?
Yeah, thanks, Chuck. So we have important collaborative initiatives targeting specific communities where there might be a higher prevalence, let's say, of neuropathy, as Chuck mentioned, or trying to improve eye screening, with the use of fundoscopic cameras, for instance, at the point of care. So those partnerships allow us to reach communities in ways we may not have been able to, and then also to have a dedicated focus where we can scale up, hopefully, to other communities that might also benefit from those programs.
And Venkat Narayan and Mo Ali and Mary Beth have been working with several international programs. What is the ADA doing to link our effort with international societies?
We international reach, mentioned the standards of care. We know that reach the 7 million is beyond.
Something is going on with your microphone.
Can you hear me?
Yeah, better.
Okay. So the standards of care has a tremendous international reach. And so we know that many countries around the world are using the standards of care in particular. And we have various professional education programs. We had a Best in China program that was done last year. We have a technology program that was done in South America and Brazil. We have different education programs that are done in different communities around the world. And we know that our scientific sessions, 1/3 of our attendees are also international. And so we look continually to partner with those societies around the world. There's a lot of opportunities there, and we continue to explore different ways to partner. Would love to. I know that there at Emory, you all have a great global center. I know Venkat has been there for a long time doing that. So we'd love to, talk more about that. But it is definitely, diabetes is a global issue. We know that we can't just do this alone, that we have to work together. Many of our consensus documents are with other countries as well. We work closely with EASD in Europe too. So the collaborations, the partnerships, the international work together is tremendously important.
Yeah. And Rita, do you want to touch very, very briefly on the partnership that we have in Saudi Arabia?
Yeah, thanks, Chuck, for mentioning that. So DiaServe is a partnership that we were really excited to launch into last year, and it represents our first internationally accredited education recognition program in Saudi Arabia. And it serves really as a model for what's possible in other countries around the world. We see this as an opportunity to really now grow outside of the United States to offer what we just talked about, that diabetes self-management education curriculum and important education needed for people with diabetes through these accredited programs that ADA is working on in Saudi Arabia. And we're already talking with other countries in the Middle East and in Asia about expanding to them as well. So we're really excited about these international ERP programs.
Yeah, and Guillermo, to your point, any advice, any guidance? I know you were very instrumental when we were talking about focusing on obesity, any thoughts, any relationships, because, again, this is a global problem, right? So we need to look at South America, right? We need to look at Asia. We need to look at, globally all across. We need to look at Africa, right? I mean, we need to figure out, how we get more of this education out around the prevalence of diabetes. So.
Yeah, there's no question in the way that we also have the ADA India program, and you do the best of ADA in multiple countries. So there is a question for you as the CEO about funding for research. Where we are in the total budget of the ADA and what's the future? Are you planning to expand the budget for research purposes?
Absolutely. So I'm actually pleased to say, so we were at our national board member meeting last week in New Orleans, I believe. And so we got our 2026 budget approved, depending on how we finish out the year. And so, Guillermo, I think you may have been on the board at the time or just rolling off. But when I became CEO, I had talked about increasing the funding for research. And so I had said that we were going to go from, just so everybody knows on the phone, 18% of the ADA's total expenses, 18% goes to research funding. And so that's the industry average. And so if you look at American Heart Association and other associations on par, 18% is the average. I'd said in our strategic plan that we were going to go from 18 to 21% over the next couple years. And this year we've increased it to 19%. But the North Star is to get to 21%. And I understand with the funding cuts to a lot of the big organizations, NIH, NIDDK, that, the onus is on the ADA to actually step up our funding for research. So that's a big focus for us, Guillermo.
Yeah, and well, first, let me just say thank you to all of you who sent questions. And we're not going to be able to go over all of them, but I have an interesting comment that in the new recommendations on diabetes prevention, the ADA, addition to lifestyle intervention, metformin, now the ADA is supporting the use of GLP-1 or the dual agonist for those with pre-diabetes with pre-diabetes. Have you thought about the cost? Would that imply if you have 80, 90 million people with pre-diabetes and perhaps more than 50% have diabetes? How are you going to handle that tremendous impact that it's going to have on budget for health?
Thanks for that question. So it's still early. You know, we've had evidence to suggest to give good, support that these classes of medications through their weight loss benefits can be used for prevention. We know that they're not FDA approved, right? So that's important to recognize. In fact, none of even, metformin is also not FDA approved for prevention of diabetes. And so I think we're still a ways from looking at the large scale implementation of this. But I think that these new studies, this new evidence highlights how our understanding of the prevention of diabetes is evolving. So, but that's a great point that you bring up, Guillermo, in terms of the cost. And so this has to be done hand in hand with what we just talked about, which is looking at access for these medications and coverage.
And Chuck, you are a business person for 35 years. How do you see these costs and the impact on overall health in this country and around the world?
Well, I mean, look, if we don't do something about it, I know that there's been this narrative out there that we're going to bankrupt the healthcare system in the United States, and we absolutely are, right? When you think about, the top three spends of just companies in general is diabetes, it's heart, and it's cancer. And diabetes is always number one on the list. And so when we talk about, approaching from the advocacy standpoint, approaching corporations, and businesses, you just can't keep up at this rate. And so they also have a part to play in making sure their employees are healthy. I was actually looking at 60 Minutes yesterday about self-insured companies, right? And so I don't know if you saw it or not, but there are these rare disease medicines, and they aren't being able to cover some of their employees or their employees' children, and these will save lives. And so, I think again, it's going to take public-private partnerships coming together and realizes that it's not one person's problem or the other, it's our own problem, right? And so we're going to have to address this to figure out how we make people healthier. And it's about prevention and not just, curative things or putting a Band-Aid on things.
So I think, well, let me just say thank you so much to Chuck Henderson and Rita Kalyani for the tremendous presentation today. And all of you for sending your questions. So I appreciate that. One thing, I served as the ADA member for 40 years, I believe, and I serve in multiple committees. And I would like to invite all of you to get involved with the ADA. That's the way to go for all of us and to help Chuck and Rita to be successful. So look at the invitation. And of course, my first ever grant was an ADA grant. So I've received 4 of them throughout my life, and I think that would be, if I can do it, I'm sure all of you can do it. So look at ADA, and thanks so much all of you for attending. I'm more Chuck and Rita, so grateful. Thank you.
Thank you for having us.
Thank you all and happy holidays.